Welcome to this lecture on airway management. In this lesson, we will explore the structure and function of the respiratory system, techniques for maintaining an open airway, and methods for providing artificial ventilation. Proper airway management is a crucial skill for every EMT, as ensuring an open airway can mean the difference between life and death for a patient. One of the most important responsibilities of an EMT is to ensure that a patient can breathe adequately. If the ability to breathe is compromised, oxygen delivery to tissues and organs is disrupted, leading to life-threatening conditions. Oxygen reaches body tissues and cells through both breathing and circulation. In this lecture, we will discuss airway anatomy, common obstructions, and techniques used to maintain and restore airflow. The respiratory system is divided into the upper and lower airways, each playing a vital role in breathing and oxygenation. The upper airway includes the nose, mouth, pharynx, and larynx, while the lower airway consists of the trachea, bronchi, and lungs. Each of these structures works together to ensure oxygen is delivered to the body and carbon dioxide is expelled. The primary function of the respiratory system is to facilitate ventilation, which is the process of moving air in and out of the lungs. The airway structures are designed to warm, humidify, and filter incoming air before it reaches the delicate tissues of the lungs. Understanding these structures is essential for recognizing and managing airway obstructions. The upper airway includes several key structures: the nose, mouth, oral cavity, pharynx, and larynx. These components help condition the air before it reaches the lungs by filtering, warming, and humidifying it. The primary function of the upper airway is to prepare air for gas exchange in the lungs. The pharynx, a muscular tube extending from the nose and mouth to the esophagus and trachea, is divided into three sections: the nasopharynx, oropharynx, and laryngopharynx. These structures help direct air into the lower airway while preventing foreign objects from entering. The nasopharynx is the uppermost part of the pharynx and serves as a passageway for air entering through the nose. It contains mucous membranes and cilia that filter dust and small particles. Additionally, it plays a role in warming and humidifying the air before it moves further into the respiratory system. The oropharynx, located at the back of the mouth, serves as a common passageway for both air and food. The epiglottis, which is positioned superior to the larynx, plays a crucial role in protecting the airway by closing during swallowing to prevent aspiration. The oral cavity, or mouth, serves as an alternate airway when the nasal passage is obstructed. It is also responsible for speech production and houses the tongue, which can sometimes obstruct the airway in unconscious patients. The larynx, or voice box, is a complex structure made up of cartilage that houses the vocal cords. It serves as the transition point between the upper and lower airways, playing an essential role in sound production and airway protection. The larynx consists of several important components, including the thyroid cartilage, cricoid cartilage, and glottis. The thyroid cartilage forms the Adam's apple, while the cricoid cartilage is the first complete ring of the trachea. The glottis, the space between the vocal cords, plays a role in airway patency and speech. The lower airway begins at the larynx and extends into the lungs. Its primary function is to deliver oxygen to the alveoli, where gas exchange occurs. The major structures of the lower airway include the trachea, bronchi, and lungs. The trachea, commonly known as the windpipe, serves as a conduit for air entry into the lungs. It divides at the carina into the right and left mainstem bronchi, which further branch into smaller bronchi and bronchioles. The trachea and bronchi are supported by cartilage to prevent collapse, while the bronchi distribute oxygen to the lungs. These airways allow for smooth airflow during breathing and ensure that air reaches all areas of the lungs. Bronchioles, the smallest airways, are composed of smooth muscle and control airflow resistance and distribution. These structures lead to the alveoli, where oxygen is absorbed into the bloodstream and carbon dioxide is expelled. The thoracic cavity houses the heart, lungs, and great vessels, including the vena cava and aorta. These structures are essential for both respiration and circulation, ensuring oxygen is transported throughout the body. The mediastinum, located between the lungs, contains the heart, major blood vessels, esophagus, trachea, and several nerve pathways. This area plays a crucial role in both respiratory and cardiovascular functions. Breathing is a coordinated effort between the respiratory and cardiovascular systems. The body constantly regulates oxygen levels and removes waste gases like carbon dioxide. Proper gas exchange is essential for maintaining cellular function and overall homeostasis. Ventilation is the process of moving air in and out of the lungs. Oxygen enters the alveoli, where it is exchanged for carbon dioxide, which is then expelled from the body. This process ensures that oxygen is available for cellular metabolism. Ventilation is the physical process of moving air into and out of the lungs. Inhalation is an active process that requires muscular effort, primarily from the diaphragm and intercostal muscles. When these muscles contract, they create negative pressure in the thoracic cavity, drawing air into the lungs. During inhalation, the lungs expand as the chest cavity increases in size. The pressure difference between the atmosphere and the lungs allows air to move in. Partial pressure refers to the amount of gas in the air or dissolved in a fluid, such as blood. Oxygen and carbon dioxide diffuse across the alveolar membrane until equilibrium is reached. Exhalation, unlike inhalation, is usually a passive process. When the diaphragm and intercostal muscles relax, the thoracic cavity decreases in size, creating positive pressure that forces air out of the lungs. This ensures that carbon dioxide is expelled from the body. Inhalation plays a critical role in oxygen delivery to the alveoli. The amount of air moved into or out of the lungs during a single breath is known as tidal volume. Some of the air remains in areas of the respiratory system where gas exchange does not occur, referred to as dead space. The process of exhalation does not require muscular effort under normal conditions. However, during forced exhalation or respiratory distress, accessory muscles may become involved. This can be observed in patients experiencing labored breathing, where you may see retractions or increased work of breathing. The regulation of ventilation involves complex feedback mechanisms that monitor oxygen and carbon dioxide levels in the blood. When oxygen levels drop or carbon dioxide levels rise, the brain adjusts the rate and depth of breathing to maintain homeostasis. Patients with chronic lung diseases, such as COPD, may rely on a hypoxic drive to regulate their breathing. Oxygenation is the process of loading oxygen molecules onto hemoglobin in the bloodstream. This step is crucial for internal respiration at the cellular level. However, ventilation does not always guarantee adequate oxygenation, as factors such as high altitudes, toxic inhalations, or medical conditions can impair oxygen absorption. Respiration refers to the actual exchange of gases between the body and the environment. External respiration, or pulmonary respiration, occurs in the alveoli, where oxygen enters the bloodstream and carbon dioxide is removed. Internal respiration takes place at the cellular level, where oxygen is used for energy production. External respiration involves the movement of oxygen and carbon dioxide between the alveoli and pulmonary capillaries. As fresh air reaches the lungs, oxygen binds to hemoglobin in red blood cells, while carbon dioxide is released from the blood into the alveoli to be exhaled. Internal respiration is the exchange of oxygen and carbon dioxide between the systemic circulatory system and the body's cells. As oxygen is delivered to tissues, it supports metabolism, while carbon dioxide, a byproduct of metabolism, is carried back to the lungs for removal. Several factors can impair respiration, including disruptions in the nervous system, trauma, infections, and medical conditions. Chemoreceptors in the brain and vascular system constantly monitor oxygen, carbon dioxide, and pH levels, providing feedback to adjust respiratory rate and depth. Ventilation and perfusion must be matched to ensure efficient gas exchange. If either ventilation or circulation is impaired, oxygen delivery is compromised. This imbalance can lead to hypoxia, in which tissues receive insufficient oxygen, or hypercapnia, an excess of carbon dioxide in the blood. A ventilation-perfusion mismatch occurs when there is an obstruction in airflow or blood flow. If the airway is blocked, oxygen cannot reach the alveoli. If circulation is impaired, oxygen cannot be delivered to the tissues. Both scenarios can result in severe hypoxemia and respiratory distress. Intrinsic factors affecting ventilation include medical conditions such as infections, allergic reactions, and unresponsiveness that leads to airway obstruction by the tongue. Extrinsic factors include trauma or airway blockages from foreign objects, both of which require immediate intervention. External factors that affect respiration include changes in atmospheric pressure, which can reduce oxygen levels. Internal factors such as pneumonia, pulmonary edema, or chronic lung diseases like COPD can also impair oxygen diffusion and gas exchange. Circulatory compromise can also impact respiration. Trauma-related conditions such as pneumothorax, hemothorax, or cardiac tamponade can obstruct blood flow to vital organs. Conditions like anemia or shock reduce the ability of red blood cells to transport oxygen efficiently. Other causes of circulatory compromise include severe blood loss, which reduces oxygen delivery to tissues, and vasodilatory shock, which results in poor circulation due to widespread vessel dilation. These conditions can be life-threatening if not addressed promptly. A critical step in emergency medical care is assessing a patient's airway and breathing status. When evaluating a patient, you must quickly determine whether the airway is open and if the patient is breathing adequately. If the patient is unresponsive, the airway may be obstructed by the tongue or other foreign material, requiring immediate intervention. In this section, we will review how to assess and manage airway problems to ensure effective ventilation and oxygenation. When evaluating a patient's breathing, you should observe for several key signs that indicate adequate ventilation. A normal respiratory rate in adults ranges from 12 to 20 breaths per minute, with a regular pattern of inhalation and exhalation. The chest should rise and fall symmetrically, and breath sounds should be clear and equal on both sides. The patient's breathing depth, also known as tidal volume, should be sufficient to maintain oxygenation. Abnormal breathing can present in several ways. A respiratory rate below 12 breaths per minute or above 20 breaths per minute is a cause for concern. Irregular patterns, diminished or absent breath sounds, and noisy breathing such as wheezing, stridor, or gurgling indicate airway obstruction or respiratory distress. If air movement is minimal or absent, immediate intervention with assisted ventilation is required. Further indicators of respiratory distress include unequal chest expansion, increased effort when breathing, and shallow respirations. You may also notice cyanosis, or a bluish discoloration of the skin, which suggests inadequate oxygenation. Retractions, where the skin pulls in around the ribs or above the clavicles during inspiration, are another sign that the patient is struggling to breathe. Sometimes, a patient may appear to be breathing when, in reality, they are in severe respiratory failure or already in cardiac arrest. Agonal gasps are slow, irregular breaths that are ineffective and often occur after the heart stops beating. Another abnormal pattern is Cheyne-Stokes respirations, which involve a cycle of increasing and decreasing breaths followed by a period of apnea, often seen in patients with stroke or head injuries. Ataxic respirations are completely irregular breathing patterns with no identifiable rhythm, often occurring after severe brain injury. Kussmaul respirations, on the other hand, are deep, rapid breaths commonly associated with metabolic acidosis, such as in diabetic ketoacidosis, DKA. Recognizing these patterns allows EMTs to identify and treat underlying conditions quickly. Even if a patient is breathing, respiration may still be inadequate due to poor oxygen exchange. A patient's level of consciousness and skin color are excellent indicators of respiratory effectiveness. If a patient appears confused, lethargic, or has pale or cyanotic skin, their oxygenation may be insufficient, requiring supplemental oxygen or ventilation support. Pulse oximetry is a valuable tool in airway assessment and should be used as part of the patient evaluation process. A normal oxygen saturation level ranges from 94% to 100%. If levels drop below this range, the patient is likely experiencing hypoxia, requiring immediate oxygen therapy. However, oximetry should always be used in conjunction with physical assessment findings rather than relied upon alone. End-tidal CO2 measurement, or EtCO2, refers to the concentration of carbon dioxide in exhaled air at the end of a breath. It is a critical tool in airway management as it provides immediate feedback on ventilation and circulation. A low EtCO2 reading may indicate hyperventilation, decreased cardiac output, or respiratory failure, while a high reading suggests hypoventilation, respiratory depression, or airway obstruction. EtCO2 is measured using capnometry or capnography devices. Capnometry provides a numerical reading of CO2 levels, typically ranging between 35 to 45 millimeters of mercury, while capnography offers a waveform display that allows EMTs to analyze ventilation patterns in real time. This tool is especially useful in confirming endotracheal tube placement, monitoring CPR effectiveness, and assessing respiratory status. Maintaining an open airway is the first priority in patient care. Unconscious patients are at risk of airway obstruction due to the tongue falling back against the throat. The supine position is most effective for airway control, allowing EMTs to perform suctioning, airway adjunct placement, and ventilation as needed. The most common cause of airway obstruction in unconscious patients is the tongue. Other causes include vomit, blood, foreign objects, swelling from burns or allergic reactions, and trauma to the airway structures. Rapid assessment and intervention are crucial to prevent respiratory failure. The head tilt. Chin lift maneuver is a simple and effective technique used to open the airway in patients who do not have a suspected spinal injury. This maneuver helps to move the tongue away from the back of the throat, preventing it from obstructing the airway. It is the preferred method for non-trauma patients who are unconscious and not breathing adequately. Perform the head tilt, chin lift maneuver. First, position yourself beside the patient's head. Place the heel of one hand on the forehead and apply gentle backward pressure to tilt the head. At the same time, use the fingertips of your other hand to lift the chin upward. This motion extends the neck and opens the airway. Be careful not to press too hard on the soft tissues under the chin, as this could obstruct breathing instead of improving it. Even if the airway is open, a patient's mouth may remain closed, preventing proper assessment or the placement of airway adjuncts. The crossfinger technique is commonly used to open the mouth of an unresponsive patient. To perform this technique, place the tips of your index finger and thumb on the patient's upper and lower teeth. Then, push your thumb down on the lower teeth while simultaneously pushing your index finger up on the upper teeth. This motion separates the jaws and allows access to the airway for further intervention. When a cervical spine injury is suspected, the jaw thrust maneuver is the preferred method for opening the airway. Unlike the head tilt, chin lift maneuver, this technique minimizes movement of the cervical spine, reducing the risk of further injury. This maneuver is commonly used in trauma patients who are unresponsive and not breathing adequately. To perform the jaw thrust maneuver, kneel above the patient's head. Place your fingers behind the angles of the lower jaw and gently move the jaw upward and forward without tilting the head or neck. Use your thumbs to help position the lower jaw while ensuring the mouth remains slightly open. This technique should always be used in patients with suspected spinal injuries to protect the cervical spine while maintaining an open airway. Suctioning is critical in managing a patient's airway, especially if the airway is obstructed by blood, vomit, mucus, or other secretions. Without suctioning, these substances can block the airway and lead to aspiration, hypoxia, or respiratory distress. Every EMT must be proficient in using suction devices effectively to clear obstructions and maintain a patent airway. A portable or fixed suction unit should have wide-bore, thick-walled, non-kinking tubing, rigid pharyngeal suction tips, and non-rigid plastic catheters. When suctioning, always limit the duration to 15 seconds for adults, 10 seconds for children, and 5 seconds for infants to prevent hypoxia. If necessary, alternate suctioning with oxygenation to ensure adequate ventilation. Before suctioning a patient, inspect the suction unit and ensure all components are properly assembled. Test the unit by verifying that it generates a vacuum pressure of more than 300 millimeters of mercury. Always select the appropriate suction catheter based on the patient's needs. Suctioning should be performed in a controlled manner to prevent complications. Never suction for more than 15 seconds for adults, 10 seconds for children, 5 seconds for infants. Excessive suctioning can lead to hypoxia, so oxygenation should be resumed immediately after suctioning. If secretions or vomitus cannot be suctioned easily, remove the suction catheter. Log roll the patient onto their side and manually clear the airway with a gloved finger sweep. This method helps prevent the airway from becoming completely obstructed when standard suctioning is ineffective. If a patient has excessive frothy secretions, suctioning alone may not be enough. In this case, alternate between 15 seconds of suctioning and 2 minutes of ventilation. This ensures that oxygen is continuously supplied to the patient while the airway is gradually cleared. Airway adjuncts are devices that help maintain an open airway by preventing the tongue from blocking airflow. Two commonly used adjuncts are the oropharyngeal airway, OPA, and the nasopharyngeal airway, NPA. These devices allow EMTs to provide adequate oxygenation and ventilation in patients who cannot maintain their own airway. An oropharyngeal airway, OPA, is inserted into the mouth to keep the tongue from blocking the airway. OPAs are only used in unresponsive patients without a gag reflex. If a patient has an intact gag reflex, inserting an OPA may cause vomiting or laryngospasm, which can worsen airway obstruction. A nasopharyngeal airway, NPA, is an alternative to the OPA for patients who are semi-conscious or have an intact gag reflex. An NPA is inserted into one of the nostrils and extends down into the pharynx, helping to maintain airway patency. However, NPAs should not be used in patients with severe facial trauma or a suspected skull fracture, as they may cause further injury. Both OPAs and NPAs have specific indications and contraindications. OPAs are used for unconscious, apneic patients without a gag reflex. They are contraindicated in conscious patients or those with an intact gag reflex. NPAs are used for semi-conscious or unconscious patients with an intact gag reflex, but are contraindicated in cases of severe head trauma or nasal fractures. For unconscious patients who are breathing adequately, placing them in the recovery position helps maintain a clear airway and reduces the risk of aspiration. The left lateral recumbent position is preferred, as it allows fluids to drain from the mouth rather than pooling in the airway. This position should only be used for patients who do not require advanced airway management. Oxygen is essential for human survival, and certain tissues and organs require a constant supply to function properly. In emergency situations, hypoxia, or a lack of oxygen, can lead to severe complications, including organ failure and death. As an EMT, it is critical to recognize when a patient needs supplemental oxygen and how to administer it properly. Oxygen therapy can improve outcomes in patients with respiratory distress, shock, or cardiac conditions. Oxygen used in pre-hospital settings comes from two primary sources: compressed gas cylinders and liquid oxygen systems. Oxygen cylinders contain highly pressurized gas and are the most common source used by EMS providers. Liquid oxygen is an alternative that provides a larger volume of oxygen in a smaller container, making it more portable. However, liquid oxygen must be stored at extremely cold temperatures to remain in its liquid state. Because oxygen is stored under high pressure, handling oxygen cylinders requires strict safety precautions. A punctured or damaged cylinder can become a dangerous projectile, capable of causing severe injuries. To ensure safety, always secure cylinders when transporting or storing them. Never drop, puncture, or expose cylinders to extreme heat. Make sure the correct pressure regulator is firmly attached before use. Following these safety measures prevents accidents and ensures effective oxygen delivery. The pin indexing system prevents oxygen regulators from being mistakenly attached to the wrong type of gas cylinder. Each gas has a unique pattern of pinholes on its cylinder valve to ensure that only the correct regulator can be attached. This system is vital for preventing mix-ups between oxygen, carbon dioxide, and other gases, which could have life-threatening consequences. Pressure regulators are used to reduce the high pressure of oxygen inside a cylinder to a safe and usable range, typically 40 to 70 psi. Some regulators include a quick connect fitting or a flow meter to allow for precise control of oxygen delivery. The correct selection and attachment of a pressure regulator ensure that oxygen is delivered at the appropriate rate for the patient's condition. Flow meters are devices that control the rate at which oxygen is delivered to a patient. There are two primary types: pressure-compensated flow meters, which maintain accuracy at different tank pressures; Borden gauge flow meters, which are not affected by gravity and are commonly used in portable oxygen tanks. Choosing the correct flow meter and setting ensures that patients receive the right amount of oxygen without waste or underdelivery. While oxygen is life-saving, improper use can cause complications. The two main hazards of supplemental oxygen are combustion risk. Oxygen does not burn, but it accelerates combustion, meaning that open flames, sparks, or smoking near oxygen sources can cause a fire. Always ensure proper ventilation and keep oxygen tanks away from ignition sources. Oxygen toxicity. Breathing high concentrations of oxygen for prolonged periods can damage lung tissues. Patients with COPD or other chronic lung diseases are particularly susceptible, and oxygen should be administered at the lowest effective dose. Since oxygen supports combustion, EMTs must follow strict fire safety protocols when using oxygen in the field. To minimize fire hazards, never allow open flames or smoking near an oxygen source. Ensure the area is well ventilated when using oxygen. Never leave an oxygen cylinder standing unattended, as it may fall and cause damage. By following these safety measures, EMTs can prevent accidental fires and ensure oxygen therapy is delivered safely. Not all patients require high concentrations of oxygen. In some cases, excessive oxygen administration can lead to oxygen toxicity, which damages lung tissue over time. This is particularly concerning for patients with COPD, where high oxygen levels can suppress their hypoxic drive, reducing their respiratory effort. When pulse oximetry is available, oxygen therapy should be adjusted to maintain an SpO2 level of 94% or higher, while avoiding unnecessary overoxygenation. Oxygen is a vital part of emergency care, and selecting the right delivery device depends on the patient's condition. The most common options include the non-rebreathing mask, which provides up to 90% oxygen for patients with adequate breathing, and the nasal cannula, delivering 24 to 44% oxygen for those needing lower support. Other devices, like the bag mask device, provide artificial ventilation for patients who can't breathe adequately on their own. Venturi masks allow precise oxygen concentration adjustments, while tracheostomy masks are used for patients with stomas. Choosing the right device ensures effective oxygenation and prevents complications. In the next slides, we'll explore each device in more detail. The non-rebreathing mask is one of the most effective ways to deliver high concentrations of oxygen to a patient who is breathing adequately but showing signs of hypoxia. It consists of a face mask with an attached reservoir bag that stores oxygen. One key feature is the one-way valve, which prevents the patient from rebreathing exhaled gases while allowing high-flow oxygen to be inhaled. This ensures a high concentration of oxygen delivery, making it ideal for patients with respiratory distress, shock, or carbon monoxide poisoning. Before placing a non-rebreathing mask on a patient, always ensure the reservoir bag is fully inflated. Oxygen flow should be set between 10 and 15 liters per minute. If the bag collapses when the patient inhales, increase the oxygen flow rate. When properly applied, this mask can deliver up to 90% oxygen. However, it is not suitable for patients who are apneic or in need of ventilatory assistance, as it requires the patient to breathe on their own. In those cases, a bag mask device would be needed. The nasal cannula is a simple, low-flow oxygen device that consists of two small prongs inserted into the nostrils. It is commonly used for patients who require mild oxygen support or cannot tolerate a mask. This device delivers between 24% and 44% oxygen, depending on the flow rate and the patient's breathing effort. The recommended flow rate is between 1 and 6 liters per minute, as anything higher can cause discomfort and nasal dryness. The nasal cannula is best suited for patients with mild hypoxia who can breathe adequately on their own. However, its effectiveness decreases if the patient breathes through their mouth or has nasal congestion. For long transports, consider using humidified oxygen to prevent irritation. If a patient requires a higher concentration of oxygen, switching to a non-rebreathing mask or another oxygen delivery device may be necessary. The partial rebreathing mask is similar to the non-rebreathing mask, but lacks the one-way valve between the mask and the reservoir bag. This design allows the patient to rebreathe a small amount of exhaled air, which contains carbon dioxide. This mask delivers approximately 80 to 90% oxygen when the flow rate is set between 10 and 15 liters per minute. It is useful in situations where maintaining a small amount of carbon dioxide in the bloodstream is beneficial, such as in some patients with hyperventilation syndromes. Before placing the mask on the patient, ensure the reservoir bag is inflated. If the bag collapses completely during inhalation, increase the oxygen flow rate to maintain proper function. The Venturi mask is a specialized oxygen delivery device that allows for precise oxygen concentration adjustments, making it ideal for patients with chronic respiratory conditions, such as COPD. This mask uses interchangeable adapters to deliver 24% to 40% oxygen, depending on the selected setting. The constant airflow ensures a stable oxygen concentration, even when the patient's breathing pattern changes. Because of its precision, the Venturi mask is often used in hospital settings or for patients who require controlled oxygen therapy. It is not commonly used in emergency pre-hospital care, but may be encountered when transporting patients from one facility to another. Patients with a tracheostomy do not breathe through their mouth and nose, requiring specialized oxygen delivery. The tracheostomy mask is designed to cover the tracheostomy opening and deliver oxygen directly into the airway. Unlike traditional oxygen masks, the tracheostomy mask is secured around the patient's neck with a strap, allowing oxygen to flow into the stoma. It can be connected to humidified oxygen to prevent dryness, which is common in patients with long-term tracheostomies. In an emergency setting, tracheostomy masks may not always be available. If needed, an alternative method is to use a standard face mask placed loosely over the stoma. When managing a patient with a tracheostomy, ensure the airway is clear and monitor for mucus buildup, which can obstruct breathing. If the patient is in respiratory distress, suctioning may be necessary before providing oxygen therapy. Some patients will not be able to maintain adequate breathing on their own and will require assisted or artificial ventilation. As an EMT, it is crucial to recognize when a patient is not ventilating effectively and intervene immediately. Signs of inadequate ventilation include altered mental status, shallow or absent chest rise, excessive accessory muscle use, and respiratory fatigue. Without intervention, these patients can rapidly deteriorate, leading to hypoxia and respiratory failure. When a patient has inadequate ventilation, the first step is to assess their breathing effort and rate. If respirations are too slow, too fast, or ineffective, you may need to provide ventilation using a bag mask device, BVM, or another airway management technique. It's important to explain the procedure to the patient if they are conscious, reassuring them while assisting their breathing. Proper mask seal, ventilation rate, and tidal volume are critical for effective oxygenation. When using a bag mask device, BVM, to assist ventilation, ensure a proper mask seal over the patient's nose and mouth. Deliver one breath every 5 to 6 seconds for adults and every 3 to 5 seconds for children and infants. Watch for adequate chest rise to confirm effective ventilation. After 5 to 10 breaths, reassess the patient's condition and continue ventilations as needed. If the patient remains hypoxic, consider adjusting the mask fit or ventilation technique. If a patient stops breathing, artificial ventilation must begin immediately. There are several methods. Mouth-to-mask ventilation using a barrier device. 1 or 2 person BVM ventilation for more controlled oxygen delivery. In cardiac arrest scenarios, ventilation should be coordinated with high-quality chest compressions to ensure oxygenated blood reaches vital organs. It's important to understand the difference between normal breathing and positive pressure ventilation, PPV. In normal breathing, the diaphragm contracts, creating negative pressure that pulls air into the lungs. With PPV, air is forced into the lungs, which can affect blood circulation and cardiac output. This is why proper ventilation technique is essential to avoid complications like gastric distension or decreased perfusion. When providing positive pressure ventilation, be mindful of potential complications. Increased intrathoracic pressure, which can reduce blood return to the heart. Excessive tidal volume, leading to lung overexpansion and barotrauma. Gastric distension, which increases the risk of vomiting and aspiration. To minimize these risks, ventilate at the appropriate rate and volume, ensuring only visible chest rise with each breath. In some cases, mouth-to-mask ventilation may be necessary. This method uses a barrier device to protect both the provider and patient. Allows for better control over tidal volume and oxygenation compared to BVM ventilation. Can be connected to supplemental oxygen to deliver a higher oxygen concentration. A bag mask device, BVM, is a common tool for artificial ventilation. However, it requires proper technique to be effective. A 2-person technique is preferred when possible, as one rescuer can maintain the mask seal while the other squeezes the bag. When using a 1-person technique, the EC clamp method is recommended to secure the mask. One common issue during ventilation is gastric distension, which occurs when air enters the stomach instead of the lungs. To prevent this, ensure the airway is properly positioned. Ventilate at an appropriate rate, not too fast or forcefully. Monitor for abdominal distension and adjust technique if necessary. If distension occurs, reposition the head and check for airway obstruction before continuing ventilations. If gastric distension becomes severe, it may cause vomiting and increase the risk of aspiration. In this case, immediately suction the airway to clear any obstructions. Reassess mask fit and ventilation technique to prevent further air entry into the stomach. Adjust the ventilation rate to ensure only adequate chest rise is observed. Proper airway positioning and careful ventilation are crucial in reducing this risk. A newer method called passive ventilation can be beneficial for patients receiving chest compressions. During compressions, air is naturally pulled into the lungs as the chest expands. This can be enhanced by using an oropharyngeal airway (OPA) and supplemental oxygen. While passive ventilation does not replace traditional ventilation, it can improve oxygenation in cardiac arrest patients. Some EMS agencies use an automatic transport ventilator (ATV) or resuscitator, which is a manually triggered device that delivers consistent tidal volume and rate, frees the EMT to perform other tasks, lacks the precision of hospital ventilators, but is effective in pre-hospital settings. Understanding the benefits and limitations of each ventilation method will help ensure the best care for patients requiring artificial ventilation. Continuous positive airway pressure, CPAP, is a non-invasive ventilation method used for patients in moderate to severe respiratory distress. It is commonly used in conditions such as congestive heart failure, CHF, chronic obstructive pulmonary disease, COPD, and pulmonary edema. CPAP works by maintaining positive pressure in the airways throughout the breathing cycle, preventing alveoli from collapsing and improving oxygen exchange. Many people with obstructive sleep apnea use CPAP at home, but in the pre-hospital setting, it can be life-saving for patients with respiratory failure. CPAP increases pressure in the lungs, which has several benefits. It opens collapsed alveoli, improving gas exchange. It pushes more oxygen across the alveolar membrane into the bloodstream. It forces excess fluid back into the pulmonary circulation, reducing symptoms of pulmonary edema. By supporting ventilation without the need for intubation, CPAP reduces the risk of complications and can help stabilize patients before transport. CPAP therapy is delivered through a face mask secured with straps to maintain a tight seal. The device generates continuous airflow at a pressure setting between 7.0 and 10.0 centimeters H2O, depending on the patient's needs. However, CPAP should be used with caution in patients with low blood pressure, as the increased pressure in the chest can reduce venous return to the heart, potentially worsening hypotension. CPAP should be considered when the patient is alert and able to follow commands, shows signs of moderate to severe respiratory distress, has a respiratory rate greater than 26 breaths per minute, has a pulse oximetry reading below 90% despite supplemental oxygen. Early CPAP use can significantly improve patient outcomes by preventing further respiratory decline and reducing the need for more invasive airway management. While CPAP is effective, it is contraindicated in certain situations. It should not be used if the patient is in respiratory arrest or is not breathing adequately, is unresponsive or unable to follow commands, has hypotension, low blood pressure, has signs of a pneumothorax or chest trauma, is vomiting, or has active gastrointestinal bleeding. If a patient meets any of these criteria, alternative ventilation methods, such as a bag mask device, BVM, should be used instead. Other contraindications for CPAP include a tracheostomy, as the mask will not function correctly over the stoma, severe facial trauma, which may prevent a proper mask seal, cardiogenic shock, where increased airway pressure could worsen circulation problems, the inability to sit upright, as CPAP is less effective in a supine position. In these cases, CPAP should not be used, and alternative airway management should be considered. Proper CPAP application is crucial for its effectiveness. As the patient exhales, the resistance from the CPAP machine creates a back pressure, keeping small airway structures open. When applying CPAP, ensure a good mask seal to prevent air leaks. Start at low pressure settings and adjust based on patient response. Continuously monitor respiratory effort and oxygen saturation to assess effectiveness. Although CPAP is a valuable tool, there are potential complications. Some patients may feel claustrophobic due to the mask. Pneumothorax, collapsed lung, can occur if pressure becomes too high. CPAP may lower blood pressure, reducing cardiac output. If the patient's condition deteriorates, CPAP should be discontinued, and positive pressure ventilation with a bag mask device should begin immediately. Some patients have had a laryngectomy, meaning their airway has been surgically altered, and they breathe through a tracheostoma instead of their nose and mouth. This presents unique challenges in airway management, requiring EMTs to adjust their approach when providing oxygen or ventilation. A tracheostomy tube is often placed in the stoma to maintain an open airway. Unlike traditional airway management, a head tilt, chin lift, or jaw thrust maneuver is not required for these patients. When providing oxygen therapy to a patient with a tracheostomy, use a tracheostomy mask if available to cover the stoma. If a mask is unavailable, a standard face mask can be placed loosely over the opening. In cases of respiratory distress, oxygen can be administered through a bag mask device, BVM, connected to the tracheostomy tube. Proper sealing of the airway is critical, as leaks around the stoma can reduce ventilation effectiveness. If a patient with a tracheostomy tube is not breathing adequately, ventilate directly through the tube using a BVM. If there is no tube present, use a pediatric or infant mask to form a seal over the stoma. If you cannot ventilate effectively, suction the stoma to remove secretions that may be obstructing the airway. In severe cases, covering the stoma and attempting mouth-to-mask ventilation may be necessary if the patient still has an open connection to the upper airway. A complete airway obstruction is a life-threatening emergency that requires immediate intervention. It can occur due to a foreign object, swelling, trauma, or the patient's own tongue blocking the airway. In adults, choking often occurs while eating. In children, small objects, food, or toys can become lodged in the airway. Recognizing the signs early and providing rapid treatment can be the difference between life and death. In unconscious patients, the most common cause of airway obstruction is the tongue falling back into the throat due to muscle relaxation. Other causes include swelling from allergic reactions or infections, trauma, which can lead to bleeding and tissue damage. If the airway is partially obstructed, listen for stridor, wheezing, or gurgling sounds, which indicate reduced airflow. A mild airway obstruction allows the patient to breathe and cough, though they may be in distress. Signs include noisy breathing, such as wheezing or gasping, coughing with good air exchange. If a patient is coughing forcefully, do not interfere. Encourage them to continue coughing to expel the object on their own. If a patient has poor air exchange with increasing difficulty breathing, signs of cyanosis, or a weak cough, immediate treatment is required. A severe airway obstruction means the patient cannot breathe, talk, or cough effectively. They may use the universal choking sign, grasping their throat, and become cyanotic due to lack of oxygen. For a conscious adult or child with a complete airway obstruction, perform abdominal thrusts, Heimlich maneuver, until the object is expelled or the patient becomes unconscious. If the patient is pregnant or obese, perform chest thrusts instead. For infants, use a combination of back slaps and chest thrusts to clear the obstruction. If the patient becomes unresponsive, lower them to the ground and begin CPR. After each set of 30 chest compressions, check the airway for visible obstructions before giving breaths. If you see the object, attempt to remove it with a finger sweep, but only if it is visible. If no object is seen, continue chest compressions and rescue breaths until the obstruction is cleared or ALS arrives. When a foreign object obstructs the airway, quick and decisive action is needed to restore breathing. The appropriate intervention depends on whether the patient is conscious or unconscious. For a conscious patient with a complete obstruction, use abdominal thrusts, Heimlich maneuver, for adults and children, back slaps and chest thrusts for infants under 1 year old, chest thrusts for pregnant or obese patients. Encourage a forceful cough if the obstruction is mild, and always monitor for worsening symptoms. Dental appliances, such as dentures, bridges, and braces, can pose an airway obstruction risk if they become dislodged during an emergency. As an EMT, you need to assess whether a patient's dental appliance should be left in place or removed to ensure a clear airway. Well-fitting dentures should be left in place, as they help maintain the structure of the mouth and improve mask seal during ventilation. Loose or poorly fitting dentures should be removed, as they may block the airway or interfere with assisted ventilation. Always check the mouth for broken dental pieces or foreign objects before initiating airway management or ventilation. Facial injuries can present serious airway challenges, as the rich blood supply to the face can lead to heavy bleeding, swelling, and airway obstruction. Key concerns with facial bleeding include blood pooling in the airway, causing choking or aspiration, swelling from trauma, potentially obstructing airflow, broken teeth or debris, which can become airway obstructions. Control bleeding quickly using direct pressure, and be prepared to suction the airway as needed to prevent aspiration. If airway compromise is suspected, initiate advanced airway management as soon as possible. In some cases, advanced life support (ALS) airway procedures may be required to secure a patient's airway. As an EMT, your role is to assist advanced providers in performing procedures such as endotracheal intubation or supraglottic airway insertion. Your responsibilities may include pre-oxygenating the patient using a bag mask device, BVM, to improve oxygen saturation before intubation, assembling and checking airway equipment for functionality, providing suctioning assistance to clear the airway, securing the advanced airway device once it has been placed. A useful acronym to remember this process is BMAGIC. B, bag mask ventilation prior to intubation. E, evaluate the airway for difficulties. M, manipulate the airway position if needed. A, attempt first pass intubation. GI, use a supraglottic airway if intubation fails. C, confirm placement and correct issues as needed. While EMTs do not perform these advanced procedures, your ability to assist can greatly improve patient outcomes.